welcome to my channel. We have started our CVS unit and we have already discussed the atrial fibrillation, supraventricular tachycardia, stable angina, congestive cardiac failure, myocardial infarction and rheumatic fever. Today we will discuss the rest of the topics. So starting from mitral stenosis. What is mitral stenosis? It is a valvular heart disease. Okay, it is a valvular heart disease and condition is characterized by narrowing of the mitral valve orifice resulting in left atrial hypertrophy and dilation. Okay, along with mitral stenosis, we will also learn the mitral regurgitation and mitral valve prolapse. So it is better to learn these three topics in comparison. What is mitral stenosis? It is a condition characterized by narrowing of the mitral valve orifice, resulting in left atrial hypertrophy and dilation. Mitral regurg is characterized by retrograde blood flow into the left atrium during systole through a mitral valve that does not fit together. Mitral valve prolapse is the bulging back of mitral valve into left atrium during systole. Which is called mitral valve prolapse. This is called floppy mitral valve or myxomatous mitral valve. Now, the causes of mitral valve stenosis are rheumatic fever, heart diseases, mitral annular calcification, SLE, and carcinoid, etc. The causes of mitral regurgitation are rheumatic fever, left side heart failure, SLE, endocarditis, and Marfan syndrome. The causes of mitral valve prolapse are idiopathic, familial, Marfan syndrome, and Ehlers-Danlos syndrome. The investigations for mitral stenosis are ECG, which shows atrial fibrillation and bifid waves, then X-ray chest, that is enlarged left atrium and Curly's B line, then echo, that is enlarged left atrium, narrow fish mouth orifice, and thickened immobile cusp. The investigation for mitral regurg are ECG, that is bifid P wave due to left ventricular hypertrophy. The X-ray chest show enlarged left atrium and enlarged left ventricular, pulmonary venous congestion, and pulmonary edema. The echo is the best initial test for mitral regurgitation, and cardiac catheterization is the most accurate. The mitral valve prolapse investigation are ECG, which may be normal or may show arrhythmias such as SVT. Then echocardiography, which is the diagnostics of mitral valve prolapse and show one or both mitral valve leaflet bulging. The treatment options for mitral regurg are, that is diuretic for pulmonary edema, salt restriction, warfarin for atrial fibrillation, endocarditis prophylaxis not routinely recommended, beta blockers for control of heart rate. The surgical options are balloon valvotomy, a balloon inserted into mitral valve repair to widen and to overcome stenosis, mitral valve replacement in case of MR. Now, the management for mitral regurgitation is ACE inhibitor and ARBs for hypertension and reduction of afterload drug of choice. Anticoagulants and digoxin are given if present. The surgical treatment for mitral regurgitation is intra-aortic balloon pump and valve replacement. For mitral valve prolapse, the management options are aspirin, beta blockers for chest pain and palpitations, and anticoagulation. Endocarditis prophylaxis not recommended. The surgical are mitral valve prolapse plus severe surgical interventions are done in the case of mitral valve prolapse along with severe mitral regurgitation. The complications of mitral stenosis are pulmonary hypertension, heart failure, heart enlargement, atrial fibrillation, and blood clots. The complications for atrial fibrillation are bacterial infection of the valve, heart failure, dilatation of the heart, and pulmonary hypertension. The complications of mitral valve prolapse are heart failure, atrial fibrillation, infective endocarditis, and pulmonary hypertension. Now we are having a scenario that there is 18-year-old thin girl visits chest pain and palpitations on auscultation mid systolic murmur and increase on standing and decrease on squatting position. These are the symptoms and signs for mitral stenosis. These are for mitral regurg. The mitral stenosis symptoms are exertional dyspnea, fatigue, left atrial enlargement, palpitations due to atrial fibrillation, pulmonary hypertension, Ordner syndrome, hoarseness of voice from left atrium, pressing on recruitment laryngeal nerve, and the signs are malar facies, pink cheeks, loud S1 and P2, low pitch mid diastolic murmur at apex and apex bit localized and tapping. The symptoms for mitral regurg are pulmonary edema, cardiogenic shock, hypotension, left ventricular heart failure, and subacute infective endocarditis. The sign for mitral regurg are forceful displaced with systolic thrill, soft S1, wet spreading S2, S3, high pitch blowing, and pan systolic murmur at apex radiating to under axilla. Now coming towards the aortic stenosis. Okay. Uh, oh, aortic stenosis. Okay. So up till now we have discussed the mitral stenosis and the mitral stenosis, mitral regurgitation, and mitral valve prolapse. Then its clinical features, the causes, the investigations, then the treatment options, that is both medical and surgical, then the complications, then the signs and symptoms. Now coming towards aortic stenosis. Aortic stenosis. So we are having a scenario that there is a 55-year-old man having dyspnea and occasional chest pain on breast walking, and cardiac impulse is palpable on left fifth intercostal space outside mid-clavicular line, and heaving heart systolic murmur at base, which was audible at carotid valvular lesion, and justify and then the causes and then enumerate complications and ECG changes. Another scenario that we are having is that there is a 25-year-old and who is having fatigue and fever for 1 month, and dyspnea on brisk walking on examination pale, and at fifth intercostal space at mid clavicular line, and heaving heart systolic murmur at base orbit audible at carotid palpable spleen, urinary show RBC and RBC cast. So what is the diagnosis, the complication, the investigation and treatment? The definition of aortic stenosis is that it is characterized by stenotic aortic valve which causes obstruction to the left ventricle outflow, which results in left ventricular hypertrophy. The causes of aortic stenosis are calcification and degeneration of the normal valve, calcification and fibrosis of the congenitally bicuspid aortic valve, and the rheumatic valvular disease. The investigations for aortic stenosis are ECG, that is left ventricular hypertrophy, chest X-ray, cardiomegaly, calcification and pulmonary congestion, and echo which show vegetation and valve damage. The complication of aortic stenosis are heart failure, stroke, endocarditis, arrhythmias, and death. So we have studied the aortic stenosis, its scenario, then the definition, the causes, the investigation options, and then the complications. Now coming towards aortic regurg, we are having a scenario that a patient is presented with palpitation and increase, especially when lying on left side, along with breathlessness, bounding pulse, collapsing in nature, mid-diastolic murmur in fifth intercostal space, especially when sitting forward. So the definition of aortic regurg is that it is retrograde blood flow into left ventricle due to an incompetent valve or dilated valve. The clinical features of aortic stenosis are pulmonary edema, hypotension, cardiogenic shock, asymptomatic apex beat is displaced, and heaving is forceful. The investigation options for aortic regurg are ECG, that is left ventricular hypertrophy, chest X-ray, left ventricular dilated ascending aorta, and echo, dilated left ventricular hyperdynamic, left ventricular and diastolic fluttering, Doppler, cardiac catheterization, MRI, and angiography. Nuclear scans are done, MR and CT scan is done, and aortography, that is dilated aorta, is done. The management options for aortic stenosis are general and specific. The general are asymptomatic patients, conservative management, BP control with ACE inhibitors, salt restriction and diuretics, restriction of the strenuous activity, and annual echocardiogram. The specific management is aortic valve replacement, which is indicated in symptomatic patients. Asymptomatic patients, ejection fraction less than 55%, and left ventricular and systolic diameter is greater than or equal to 55 mm. Okay, so we have discussed the aortic regurg, the scenario for aortic regurg, then the definition, the clinical features, and the investigations, which are ECG, chest X-ray, echo, Doppler, cardiac catheterization, MRI, and angiography. Then the management, which are general and specific management. Now coming towards infective endocarditis, we are having a scenario that there is a 55-year-old man presented with fever and fatigue for last 1 month, having dyspnea on brisk walking. On examination, he was pale. Apex beat was palpable in left fifth intercostal space at mid-clavicular line, and was having harsh systolic murmur at base, which was audible at carotid. He had palpable spleen. Another scenario is that there is a 44-year-old male with malaise and fever. She is not feeling well for 6 months. On examination, apical pansystolic murmur and splenomegaly is present, which valvular lesion is present here. And what are the diagnosis, management, investigation, and complications options? Another scenario is that there is a 25-year-old young man, 1 month history of low-grade fever, fatigue, joint pain, and weight loss, dyspnea on brisk walk. On examination, he is pale and febrile, and precordium apex beat is palpable in left fifth intercostal space in mid-clavicular line, and is having cardiac impulse. Harsh ejection systolic murmur at base radiating to carotid. He has palpable spleen, and urinary shows RBC and RBC crisis. Now, what is the definition? Inflammatory disorder of endocardial surface mainly involving walls that results from infection by any of several types of microorganisms, including bacteria, fungi, and rickettsia. The causes of infective carditis are abnormal valve, risk of bacteremia, and cost of organism. The acute risk factors are Staph aureus, subacute is Staph viridans, and prostatic valve is Staph epididymitis, and drugs are Staph aureus. Now, the types are acute endocarditis and subacute endocarditis. The acute endocarditis is due to high virulence organism, and subacute endocarditis is due to low virulence organisms. Now, the clinical features are fever, chills, fatigue, and new murmur. These are the acute clinical features, and the chronic clinical features are anemia, splenomegaly, and clubbing. The investigation options are blood culture, that is most accurate, and take at least 3 to 6 cultures. Then CBC, which is C-reactive protein, and ESR, which is raised in infection. Then echocardiography is done for detecting vegetation, and TEE more sensitive and more specific. Then X-ray test is done for cardiomegaly. Serologic tests are done for R factor, that is rheumatoid factors. Urine analysis is done for infection, and for diagnosis, modified Dukes criteria is used. Okay, now for definitive diagnosis, 2 major or 1 major plus 3 minor criteria or 5 minor criteria give the diagnosis of the infective endocarditis. In major criteria, we are having positive blood culture, typical organisms from 2 cultures which are consecutive, then persistent positive blood cultures taken greater than 12 hours apart, and endocardial involvement documented by echocardiographic findings or new valvular regurgitation. The minor criteria are predisposing heart lesions, intravenous devices, fever greater than or equal to 38 degrees C, embolic phenomena, suggestive echocardiographic findings, and suggestive blood culture findings. The treatment options are acute bacterial endocarditis, that is vancomycin plus gentamicin, then subacute bacterial endocarditis, ceftriaxone plus gentamicin or benzyl penicillin plus gentamicin. Prostatic valve oral, that is vancomycin plus gentamicin plus rifampicin is used. Specific antibiotic therapy is provided. It should be according to culture and sensitivity and should be continued for at least 4 weeks, for example, viridin streptococci and ceftriaxone. The surgical options are required for removal of vegetation and replacement of valve. Prophylactic antibiotics are used for the endocarditis, which is recommended before invasive procedure in certain patients, and the drug of choice is amoxicillin. Condition where antibiotic prophylaxis is definitely recommended are prostatic cardiac valve, past history of infective endocarditis, unrepaired cyanotic diagnosis. Complications are myocardial abscess, pulmonary emboli, and aneurysm formation. So we have discussed the topic infective endocarditis along with the scenario. First, we discussed the scenario that there is a patient who is having the history of low-grade fever and fatigue and joint pain and weight loss. Then this dyspnea on brisk walking, and on examination he is pale and febrile, and precordium apex beat is palpable in left fifth intercostal space and mid-clavicular line, and also he is having heaving cardiac impulse and harsh ejection systolic murmur at the base which is radiating to the carotids. He has palpable spleen and urine RE shows RBC and RBC crisis. So what is the definition? Then what are the causes and risk factors? Then what are the types of endocarditis? Then the clinical features, then the investigations, that is blood culture, CBC, C-reactive protein and ESR, echocardiography, X-ray test, serologic test, urine analysis, and for the modified diagnosis we use Dukes criteria. Then the definitive diagnosis which have major criteria and minor criteria. Then the treatment options which are acute bacterial endocarditis, subacute bacterial endocarditis, prostatic valve endocarditis, specific antibiotic therapy, surgery, and prophylaxis. Then the condition where antibiotic prophylaxis is definitely recommended, and then the complications. Now coming towards hypertrophic obstructive cardiomyopathy, we are having a scenario that there is a 35 years man admitted in hospital following a collapse while jogging. The history of a blackouts is present. Also, elder brother died at younger age. On examination, he is well-looking man with no neurological signs. Loud systolic murmur along left sternal border with prominent apical impulse is present. So what is the definition? It is the group of inherited conditions that produce hypertrophy of myocardium. Okay, the closed differentials are aortic stenosis. The causes are autosomal dominant mutation. The clinical features are exertional dyspnea, exertional chest pain, arrhythmias, that is palpitation, syncope, and sudden cardiac death. The investigations options for hypertrophic cardiomyopathy are ECG, that is left ventricular hypertrophy, large abnormal Q wave, ST and T wave changes. Then echocardiography, that is asymmetrical septal left ventricular hypertrophy, vigorously contracting ventricle, and systolic anterior motion of the mitral valve. Then the cardiac catheterization, which is the most accurate test. The management options are medical and surgical. The medical options are beta blockers, calcium channel blockers, amiodarone, that is for arrhythmias, anticoagulants for atrial fibrillation, implantable defibrillators for syncope, and don't give digoxin vasodilator in this case. The surgical options are done when medical therapy fails, that is alcohol, septal ablation, surgical myomectomy, and transplantation is done. The life-threatening of hypertrophic obstructive myopathy is occur and it leads to congestive cardiac failure and sudden death. The symptoms and signs of the hypertrophic cardiomyopathy are exertional dyspnea, exertional chest pain, arrhythmias, that is palpitation, syncope, sudden cardiac death, most common cause of sudden cardiac death in young athletes. The signs are double apical pulsation, pan-systolic murmur at apex, that is mitral rigors, jerky carotid pulse, ejection systolic murmur due to left ventricular outflow obstruction. Towards pericarditis. We have discussed hypertrophic obstructive cardiomyopathy, that is along with the scenario and the definition, then the closed differential and the causes, the clinical features, then the investigation options. Then we discuss the management options, that is medical and surgical, then the life-threatening of hypertrophic obstructive cardiomyopathy, then the signs and symptoms, and then the arrhythmias. Now coming towards pericarditis, the scenario is that there is a young schoolboy complain of chest pain of 3 days duration, which is continuous, getting worse on lying flat and relieved by sitting up. No relationship to exertion, preceded by upper respiratory tract infection 10 days ago. On examination, he is pulse is 100 per minute and regular BP is 110/70 and temperature is 100 degree Fahrenheit. Raised GVP is present. What is the diagnosis? What is the finding on auscultation, the investigation, and the treatment? So the causes are infectious pericarditis, that is viral or bacterial. The viral is due to Coxsackie virus and the bacterial is due to tuberculosis. The post-MI and surgery and radiotherapy are the causes. The clinical features are chest pain is pleuritic, aggravated with deep breathing. Then chest pain aggravated by lying supine, coughing, and deep inspiration, and relieved by sitting up and leaning forward. The investigation options for pericarditis are ECG, that is ST segment elevation, PR interval, and depression, very specific indication. Then the chest X-ray is done. It may show effusion if present. Echocardiogram is done for pericardial effusion. Viral titer is done for in case of viral pericarditis. The treatment options are aspirin 600 mg 6 times a day and sets into methacin 25 mg to 3 daily. Then steroids. The purulent pericarditis, जैसे antibiotics and pericardiocentesis if necessary. Surgical drainage. Tuberculous pericarditis is done anti-tuberculous chemotherapy plus 3 months of the steroids. Okay, now constructive pericarditis scenario is that there is hepatomegaly, ascites, and edema with raised JVP, small signs, pulses, paradoxicus, and increased JVP on inspiration. So what are the causes? The tuberculous pericarditis, the hemopericardium, and the rheumatoid arthritis, the radiation, uremia, and post-cardiac surgery are the causes of constructive pericarditis. The clinical features are right-sided failure, that is greater than left-sided, fatigue, hepatomegaly, ascites, elevated JVP, then small signs and elevation of the JVP on inspiration. The investigation options for pericarditis are chest X-ray, that is small heart failure, pericardial calcification is present, ECG to low voltage QRX complex, and echo will show thick and calcified pericardium. The treatment options are that of underlying condition, then diuretics for fluid overload symptoms, and pericardiectomy, the surgical resection of the pericardium, and dramatic improvement with high morbidity. So we have discussed the pericarditis along with the scenario, then its causes, then the clinical features, then the investigation options, which are ECG, chest X-ray, echocardiogram, and viral titer. Then the treatment options for purulent pericarditis, for tuberculous pericarditis. Then we are having constrictive pericarditis along with the scenario, and we discuss the causes, the clinical features, and then the investigation options, which are chest X-ray, ECG, and echo. Then we discuss the treatment options. Now coming towards core pulmonale. We are having a scenario that there is a 65-year woman from Kalam, Swat, admitted in medical ward with long-standing history of productive cough, worse in winter, and shortness of breath on minimal exertion. She burnt wood and exposed to smoke in her sleeping for many years to keep her and her family warm in cold season. On examination, she is ill-looking, centrally cyanosed with mild ankle edema. On examination, ill-looking, centrally cyanosed with mild ankle edema. BP is 135/90. Raised JVP is present. Urine RE is normal. So what is the diagnosis, the investigation, the findings, and okay. So another scenario is that there is a 60-year lady, 10-year history of chronic productive cough, green sputum, and shortness of breath is present. Received anti-tubercular treatment 20 years back. On examination, she is ill-looking with edema of head. BP is 130/90 mm of Hg. JVP is rest and coarse crackles over lower zone are present. Hepatomegaly, central cyanosis is present. Urine RHO. What are the complications, investigations, and treatment? So, the definition of curve pulmonale is that it is defined as right heart ventricular hypertrophy and dilatation secondary to pulmonary hypertension, which is caused by the disease of lung parenchyma or pulmonary vessels unrelated to the left side of the heart. The causes are chronic obstructive pulmonary disease, which are most common pneumoconiosis, pulmonary fibrosis or embolism, and kyphoscoliosis, and primary pulmonary hypertension. The investigation for core pulmonale are X-ray chest, that is right ventricular enlargement and right atrial dilatation, prominent pulmonary artery, then ECG, which is done for right ventricular hypertrophy, right axis deviation, then echo and Doppler. It shows right ventricular hypertrophy and causes of pulmonary hypertension such as intracardiac shunt. The treatment options are causative treatment, that is diuretic for small dose, oxygen inhalation, digoxin, heart and lung transplantation in young patient, and AC inhibitor. The clinical features are dyspnea, cyanosis, clubbing, weakness, rest, JVP, right ventricular heave, pulmonary and tricuspid regurgitation, and murmur. So we have discussed the core pulmonale along with the scenario, then the definition, then the causes, then investigation options. Now coming towards the deep venous thrombosis, we are having a scenario that there is a 30-year-old lady presented to medical OPD, returned from Hajj after a long flight of 6 hours. Now she has been taking OCP to avoid menstruation during her Hajj period. She has pain and swelling of right leg. She has been well before and there is no history of arthritis. She is febrile, BP is 120/70 and full blood count is normal. So what is the diagnosis, investigation, management, and complication, and how to recognize clinically? The definition of DVT is that it is the formation of a blood clot in one of the deep veins of body, usually in leg. The investigation options are D-dimer, non-specific, but when low has a high negative predictive value. Then imaging studies such as duplex and Doppler ultrasound of leg. Color Doppler ultrasound of the leg veins remains the investigation of choice in patient with suspected DVT to confirm the source of thrombus and start treatment to prevent next episode. Venography is done. The treatment options are anticoagulants, for example, heparin and warfarin, thrombolytics, surgical thrombectomy, then Cabell filters to prevent acute pulmonary embolism, that is Greenfield filter on or inferior vena cava ligation. These are the most serious complications, pulmonary thromboembolism. Clinically, it can be diagnosed by the following symptoms and finding on examination, that is sudden onset of chest pain and restlessness, dyspnea, shortness of breath, pleuritic chest pain, tachypnea, cough sometimes and restlessness, dyspnea, that is shortness of breath, fever, accentuated sound, heart sound, that is S3 and S4 gallop, then release, history and examination finding consistent with lower limb DVT, anticoagulant with subcutaneous low molecular weight heparin. So we have discussed the last topic of the CVS, that is DVT, along with the scenario, then the definition, then investigations option, that is D-dimer, imaging study, then venography, then the treatment option, then the most serious complications, and how clinically it can be diagnosed by the symptoms and finding on the examination. Here we have covered our CVS subject, CVS unit. We have covered all the following topics: aortic mitral stenosis, aortic stenosis, aortic regurgitation, infective endocarditis, hypertrophic obstructive cardiomyopathy, pericarditis, constrictive pericarditis, core pulmonale, and deep venous thrombosis. In the next video, we will discuss the pulmonology of the medicine, part A section. Thanks for watching.